It's hard to form the words.
I'm trying to say...
Pathology of Fear is a medical documentary series presenting clinically documented neurologic and pathological mechanisms for educational analysis.
2 patients, 1 disease. The first patient sits in a speech clinic, not a neurology office. He is in his late 50s. His primary complaint is that words no longer come out cleanly. His sentences sound thick, slowed, slightly slurred, especially when he is tired. He has not lost vocabulary. He knows exactly what he wants to say. The problem is execution. His tongue does not move with the same precision it once did. Swallowing liquids sometimes triggers coughing. Meals take longer. His primary care physician referred him to ENT. Laryngoscopy shows no mass. Vocal cords move. There is no tumor, no stroke, no infection. The working explanation becomes reflux, stress, or age-related change, because nothing visible explains why speech has begun to fail. The second patient is not seen anywhere near a speech clinic. She presents to orthopedics. She's in her early 60s. Her complaint is weakness in her right hand. Buttons are harder to manage. Grip strength feels unreliable. A few weeks later, she notices that her foot occasionally drags when walking upstairs. There is no pain. Sensation is intact. She can feel temperature, vibration, and touch normally. An X-ray of the cervical spine is ordered. Degenerative changes are noted. Carpal tunnel syndrome is considered. Physical therapy is recommended. No one asks about speech. No one tests swallowing. There is no obvious neurological emergency. Both patients are examined. Reflexes are checked. Muscle tone is assessed. Strength is graded. Early findings are subtle. In the first patient, tongue fasciculations are either missed or dismissed as benign. In the second, slight asymmetry in hand strength is attributed to disuse or compression. Neither presentation forces immediate neurological escalation. Both patients remain cognitively intact. Both understand what is happening. Both feel something is wrong, but nothing yet appears catastrophic. The clinical pathways diverge immediately. One is absorbed into speech therapy and gastroenterology. The other cycles through orthopedics and rehabilitation. Each specialty sees a localized problem and applies a local explanation. Speech difficulty becomes a throat problem. Limb weakness becomes a joint or nerve compression problem. No one is wrong. They are incomplete. The disease responsible for both presentations does not respect specialty boundaries, and it does not announce itself in a way that demands immediate unification. Months pass. In the first patient, speech continues to deteriorate. Swallowing becomes unsafe. Weight drops. A feeding modification is suggested. In the second, weakness spreads from hand to forearm. Fasciculations appear in the shoulder. Fatigue increases with minimal exertion. Physical therapy stops helping. Still, sensation remains intact. Pain is absent. This absence of sensory involvement misleads. Many neurological diseases announce themselves through numbness, pain, or sensory loss. This one does not. Eventually, both patients reach neurology. By then, their stories sound different. One is framed as a speech and swallowing disorder with possible neurodegenerative features. The other is framed as progressive limb weakness of unclear cause. They are evaluated as separate diagnostic problems, even though the underlying pathology is identical. The disease has simply chosen different entry points into the motor system. This is how amyotrophic lateral sclerosis begins. Not as a single recognizable syndrome, but as a failure of voluntary movement that declares itself wherever motor neurons are first lost. In one case, the muscles of speech and swallowing. In the other, the muscles of the hand and leg. The difference is not the disease. The difference is anatomy. ALS does not begin everywhere at once. It begins where motor neurons fail first. The brain does not send weaker commands. The muscles do not forget how to respond. The problem is that the neurons responsible for executing voluntary movement begin to die. Which neurons fail first determines how the disease is perceived, how it is misdiagnosed, and how long it takes before the unifying diagnosis is made. From the beginning, ALS creates an illusion of two diseases, one that looks like a speech disorder, one that looks like a limb disorder. In reality, both are expressions of the same process, a process that selectively destroys motor neurons while leaving sensation, awareness, and cognition largely intact. This asymmetry is not incidental. It is the reason diagnosis fails early. It is the reason patients are fragmented across specialties. And it is the reason the disease advances quietly while the nervous system is still fully aware of what is being lost. This episode begins here, not with genetics or pathology, but with the moment the disease becomes visible in two different bodies and is mistaken for two different problems. What follows is not a comparison of severities or timelines. It is an explanation of how one disease fractures into different clinical realities, depending on where motor neuron failure first occurs. What ALS actually is: motor neuron system failure. Amyotrophic lateral sclerosis is not a disease of muscle. It is not a disease of joints, tendons, or peripheral sensation. It is a disease of the motor neuron system itself, the network of cells that allows the brain to convert intention into voluntary movement. When ALS begins, the muscles are still capable of contracting. What fails is the command pathway that tells them to do so. Voluntary movement depends on two linked populations of neurons. Upper motor neurons originate in the motor cortex and descend through the brainstem and spinal cord, carrying the signal that movement should occur. Lower motor neurons originate in the brainstem nuclei and the anterior horns of the spinal cord, projecting directly to muscle fibers. Together they form a continuous execution chain. ALS targets both populations. It does not respect the boundary between brain and spinal cord. Upper motor neuron degeneration disrupts signal initiation and modulation. As these neurons die, inhibitory control is lost. Reflexes become exaggerated. Muscle tone increases. Movements lose fluidity and precision. Lower motor neuron degeneration removes the final connection between nerve and muscle. When these neurons fail, muscle fibers lose innervation, weaken, and atrophy despite preserved sensation and blood supply. This dual involvement explains why ALS behaves the way it does. The disease is not localized. It is not restricted to one nerve or one level of the spinal cord. It advances along the motor system, destroying both the command and the execution layers of voluntary movement. Sensory neurons are spared. Autonomic function is initially preserved. Cognitive processing remains largely intact in most patients. The nervous system knows what it wants to do. It simply cannot carry it out. The anatomy of the motor system determines how ALS presents. Upper motor neurons, controlling speech and swallowing, descend through the corticobulbar tracts to brainstem nuclei that innervate the tongue, pharynx, and larynx. Upper motor neurons, controlling the limbs, descend through the corticospinal tracts to anterior horn cells in the spinal cord. When degeneration begins in one region, the first symptoms appear there. In bulbar ALS, degeneration affects motor neurons serving the cranial muscles early. Speech becomes slurred because the tongue and lips lose precise control. Swallowing becomes unsafe because coordinated contraction of pharyngeal muscles fails. Cough reflexes weaken, not because sensation is lost, but because the muscles responsible for airway protection cannot execute effectively. These failures are mechanical, not cognitive. In spinal ALS, degeneration begins in motor neurons serving the limbs. Hand weakness appears because small motor units lose innervation. Fine motor tasks fail first. Foot drop emerges as distal leg muscles weaken. Fasciculations appear as denervated motor units fire spontaneously. Sensation remains intact. Pain is minimal or absent. The absence of sensory symptoms delays recognition that the problem is neurological rather than orthopedic. ALS does not spread randomly. It advances along connected motor networks. Once degeneration begins in one region, it propagates to adjacent motor neuron pools over time. The disease does not skip directly from hand to speech or from speech to leg without anatomical continuity. This pattern creates the illusion of progression speed differences, when in reality the disease follows predictable motor pathways. Importantly, ALS does not impair the brain's ability to generate intent. Thought, memory, and awareness are preserved because the disease spares sensory cortex and associative networks in most cases. The patient remains aware of decline as it unfolds. The loss is not of identity, it is of execution. This distinction defines the fear associated with ALS. The mind remains intact while the body becomes increasingly unresponsive. There is no inflammation that resolves. There is no remyelination that restores function. Motor neurons, once lost, are not replaced. The adult central nervous system does not regenerate these cells. When degeneration begins, the trajectory is one-directional. Treatments may slow progression marginally, but they do not reverse neuronal death. Understanding ALS as motor neuron system failure clarifies why bulbar and spinal forms are not separate diseases. They are the same process, declaring itself through different anatomical entry points. The distinction matters clinically because it affects early symptoms, diagnostic pathways, and risk profiles. It does not change the underlying mechanism. From this point forward, the disease will be examined not as two variants competing in severity, but as one motor neuron degeneration that reveals itself through different functional systems. The difference between bulbar and spinal ALS is not what is destroyed. It is where the destruction becomes visible first. Bulbar ALS, when the disease enters through speech. Bulbar ALS begins in the motor neurons that control the muscles of speech, swallowing, and airway protection. These neurons reside in the brainstem, clustered in nuclei that innervate the tongue, soft palate, pharynx, and larynx. When degeneration begins here, the earliest failures appear not as weakness in the limbs, but as loss of precision in functions most people take for granted: articulation, chewing, and swallowing. The earliest symptom is usually dysarthria, not aphasia. Language formulation remains intact. Vocabulary, grammar, and comprehension are preserved. What fails is the physical execution of speech. Words emerge slowed, slurred, or nasal. Consonants lose sharpness. Speech worsens with fatigue because remaining motor units are overworked. This distinction is critical and often missed. Aphasia suggests cortical language dysfunction. Dysarthria points to motor neuron failure. Swallowing difficulty follows a similar pattern. The patient does not forget how to swallow. Sensation in the mouth and throat remains intact. The problem lies in coordination and strength of the muscles that move the bolus and protect the airway. Liquids trigger coughing. Pills feel stuck. Meals become prolonged and exhausting. Weight loss occurs not because of appetite loss, but because eating becomes mechanically unsafe and inefficient. The absence of pain and sensory loss misleads clinicians. Many disorders of the throat produce discomfort, inflammation, or visible lesions. Bulbar ALS produces none of these. Laryngoscopy appears normal. Vocal cords move. There is no mass, no infection, no ulceration. Because structure appears intact, functional explanations rise to the surface. Reflux, anxiety, muscle tension dysphonia, or age-related change are proposed. As degeneration progresses, fasciculations may appear in the tongue. These small, rippling movements represent spontaneous firing of denervated motor units. They are a hallmark of lower motor neuron involvement. When observed, they are diagnostic. When missed, the disease continues unrecognized. Subtle tongue atrophy may also develop, but it is easily overlooked without deliberate examination. Upper motor neuron involvement contributes additional features. Loss of inhibitory control produces spasticity of bulbar muscles. The jaw may feel stiff. Emotional expression becomes dysregulated, leading to inappropriate laughing or crying, a phenomenon known as Pseudobulbar affect. This is not emotional instability. It is loss of cortical control over brainstem motor expression. Airway protection becomes compromised as the disease advances. The muscles responsible for effective coughing weaken. Secretions accumulate. Aspiration risk increases. Pneumonia becomes a threat long before respiratory failure from diaphragm weakness develops. This sequence is specific to bulbar involvement and contributes to poorer early outcomes if not recognized. Because speech and swallowing are socially and medically sensitive functions, patients with bulbar ALS often undergo extensive evaluation before neurology is involved. ENT, gastroenterology, speech therapy, and psychiatry may all participate. Each specialty addresses a fragment of the problem. None address the underlying motor neuron degeneration. The preservation of cognition further complicates recognition. The patient explains symptoms clearly. There is no confusion, no memory loss, no behavioral change early. This coherence contradicts expectations of serious neurological disease and reinforces misclassification as functional or psychosomatic. The disease advances while credibility is questioned. Bulbar ALS appears to progress rapidly, but this is an illusion of exposure. Speech and swallowing are constantly in use. Small declines become obvious quickly. The same rate of motor neuron loss in the hand may go unnoticed longer because gross strength can compensate. The disease is not more aggressive in Bulbar-Onset, it is more visible. Eventually, limb weakness develops as degeneration spreads from brainstem nuclei into spinal motor neuron pools. At that point, the unifying diagnosis becomes clearer. By then, significant bulbar function has already been lost. The early window for accurate classification has passed. Bulbar ALS is not a different disease. It is ALS revealing itself through the motor neurons of communication and feeding first. The fear it generates is immediate because it interferes with speech and swallowing, the most fundamental interfaces between the individual and the world. The biology, however, is the same motor neuron failure that will later claim limb and respiratory function as well.
Spinal ALS, when the disease enters through the limbs. Spinal ALS begins in the motor neurons that innervate the muscles of the arms, legs, and trunk. These lower motor neurons reside in the anterior horns of the spinal cord and form the final common pathway between the nervous system and skeletal muscle. When degeneration begins here, the earliest signs appear as weakness, not pain, and as loss of precision rather than loss of sensation. The first complaint is often subtle. A hand feels clumsy. Buttons take longer. Grip strength seems unreliable. Objects are dropped without warning. In the leg, the earliest sign may be foot drop, a slight catching of the toes during walking, or difficulty climbing stairs. These changes fluctuate early, not because the disease reverses, but because remaining motor units temporarily compensate. Sensation remains intact. The patient can feel light touch, temperature, vibration, and pain normally. This absence of sensory loss is misleading. Many clinicians are trained to associate neurological disease with numbness or tingling. When these are absent, attention shifts toward musculoskeletal or peripheral nerve explanations. Carpal tunnel syndrome, cervical radiculopathy, lumbar disc disease, or overuse injury are considered first. Lower motor neuron degeneration produces characteristic signs that are often missed early. Fasciculations appear as visible twitching beneath the skin. They represent spontaneous firing of denervated motor units and are a hallmark of motor neuron disease. Early on, they may be dismissed as benign or stress-related. Muscle atrophy develops gradually as denervated fibers shrink. Because strength loss is initially focal, global weakness may not be appreciated. Upper motor neuron involvement contributes a second layer of dysfunction. As descending corticospinal input deteriorates, inhibitory control is lost. Reflexes become exaggerated. Muscle tone increases. Movements become stiff and poorly modulated, but rarely complete early in the disease. The partial nature of findings delays recognition. Spinal ALS often appears asymmetric at onset. One hand weakens before the other. Motor neuron pools are anatomically discrete. Degeneration begins locally and spreads continuously, not simultaneously across the body. Pain is not a defining feature. When pain occurs, it is usually secondary to muscle imbalance, spasticity, or joint stress, rather than primary nerve injury. The absence of pain further distances the presentation from inflammatory or compressive neuropathies and contributes to diagnostic delay. As weakness progresses, compensatory strategies fail. Tasks that relied on fine motor control become impossible. Writing deteriorates. Typing slows. Walking becomes unsafe as proximal muscles weaken and postural stability declines. Fatigue increases rapidly because remaining motor units are overburdened. Still, cognition remains intact. The patient understands what is happening and recognizes the pattern of loss. Electromyography eventually reveals widespread denervation and reinnervation, confirming motor neuron involvement. By the time EMG findings are definitive, clinical progression is usually well established. The test confirms what has already occurred. It does not prevent it. Spinal ALS is often perceived as slower than bulbar ALS. This perception arises because limb function can compensate longer than speech or swallowing. Gross motor tasks tolerate partial denervation better than fine bulbar coordination. The disease itself progresses at a similar biological rate. Visibility differs, not velocity. Over time, spinal ALS converges with bulbar involvement. Speech weakens. Swallowing becomes unsafe. Respiratory muscles are affected as degeneration reaches the phrenic motor neurons, controlling the diaphragm. The initial entry point becomes irrelevant. The disease asserts its full scope. Spinal ALS is not a localized limb disorder. It is the same motor neuron system failure seen in bulbar ALS, declaring itself first in the muscles of movement rather than the muscles of communication. The distinction matters early, when diagnosis is uncertain and misclassification common. It does not change the underlying trajectory. By the time limb weakness forces neurological unification, the disease has already claimed motor neurons that will never be replaced. What began as a hand problem or a gait issue reveals itself as a systemic failure of voluntary movement. The illusion of separation dissolves, leaving a single diagnosis that was present from the start. Same mechanism, different illusions. Bulbar ALS and spinal ALS appear, at first, to be different diseases because they reveal the same pathology through different anatomical windows. This difference in exposure creates illusions of severity, speed, and prognosis that are not rooted in biology, but in visibility and function. The underlying mechanism is identical in both forms: progressive degeneration of upper and lower motor neurons. Motor neurons are organized topographically. Those controlling speech, swallowing, and facial expression are clustered in the brainstem. Those controlling limb movement reside in discrete segments of the spinal cord. ALS does not select functions based on importance or complexity. It selects neurons based on vulnerability. Where degeneration begins determines what fails first. This anatomical reality produces the illusion that bulbar ALS is more aggressive. Speech and swallowing are high-frequency, fine motor tasks with little redundancy. Even small losses are immediately obvious and socially disabling. Limb muscles, by contrast, can compensate through recruitment of remaining motor units. Weakness may be masked for months. The disease appears slower when it enters through the limbs because the system tolerates partial failure longer. Spinal ALS creates the opposite illusion. Because limb weakness begins focally and spreads contiguously, the disease appears localized. One hand fails while the other functions. One leg weakens while walking remains possible. This focality suggests orthopedic or peripheral nerve pathology. Bulbar ALS, which affects bilateral cranial nuclei early, appears diffuse and alarming by comparison. The difference is not spread rate. It is symmetry of exposure. At the cellular level, the same processes are at work in both forms. Motor neurons experience excitotoxic stress, impaired axonal transport, mitochondrial dysfunction, and protein aggregation. Upper and lower motor neurons degenerate together, though not always at the same pace. There is no molecular distinction between bulbar and spinal ALS. They are clinical labels, not biological subtypes. Disease spread follows motor networks. Degeneration progresses to adjacent motor neuron pools through anatomical continuity. In Bulbar-Onset, spread often descends into cervical spinal segments, affecting upper limbs next. In Spinal-Onset, spread may ascend toward bulbar nuclei or descend toward respiratory motor neurons. The sequence varies, but convergence is inevitable. This convergence exposes the illusion of prognostic separation. Bulbar ALS is often described as having a worse prognosis. In reality, early bulbar involvement accelerates nutritional compromise and aspiration risk, which can shorten survival if unmanaged. The disease itself is not intrinsically faster. Its early impact on critical functions makes outcomes appear worse. Similarly, spinal ALS may appear more benign early because walking and arm function persist. This appearance fades as respiratory muscles become involved. Once the diaphragm weakens, disease stage equalizes regardless of initial entry point. Survival curves converge when measured from the point of respiratory compromise rather than symptom onset. The persistence of awareness intensifies these illusions. In both forms, cognition remains largely intact. The patient perceives decline in real time. The difference is what is lost first. In bulbar ALS, communication fails early, isolating the patient socially. In spinal ALS, physical independence erodes first, isolating the patient functionally. Both experiences arise from the same mechanism: loss of voluntary motor execution. These illusions affect diagnosis as well. Clinicians are trained to categorize disease by presenting symptom. Speech disorders follow one pathway. Limb weakness follows another. ALS breaks this framework by presenting through either pathway while remaining a single disease. Until both pathways are affected, unification is delayed. Understanding ALS as one mechanism with different entry points clarifies why early labels are misleading. Bulbar ALS is not a faster disease. Spinal ALS is not a milder one. They are different faces of the same process, revealed by anatomy rather than biology. The fear embedded in these illusions is not fear of difference, but fear of realization. When the disease finally converges, the distinction between bulbar and spinal disappears. What remains is a motor neuron system that can no longer execute voluntary movement, regardless of where failure began. Why diagnosis FIILS specialty silos and timing? ALS is rarely missed because it is unknown. It is missed because it enters the medical system through doors that are not designed to recognize it early. The disease fragments itself across specialties long before it is unified under a neurological diagnosis. Bulbar ALS often begins its diagnostic journey in ENT clinics. Speech changes are evaluated as vocal cord dysfunction, reflux, or age-related dysphonia. Swallowing difficulty is attributed to esophageal motility issues or anxiety. Imaging focuses on structural lesions that are not present. Because laryngoscopy and imaging appear normal, the absence of visible pathology is interpreted as absence of disease. Spinal ALS follows a different path. Limb weakness is absorbed into orthopedics and rehabilitation. Cervical spine degeneration is common in older adults and offers a convenient explanation. Carpal tunnel syndrome, ulnar neuropathy, or lumbar disc disease are considered. Physical therapy is prescribed. Temporary plateaus are misread as improvement. The underlying motor neuron loss continues unnoticed. Neurology is often consulted late, and even then the picture may be incomplete. Early ALS rarely presents with the full combination of upper and lower motor neuron signs required for diagnostic certainty. Reflexes may be brisk without weakness, or weakness may exist without clear spasticity. Fasciculations may be subtle. Atrophy may be focal. The partial nature of findings invites watchful waiting. Electromyography, the most informative diagnostic tool for ALS, has limitations early. Denervation must reach a threshold before widespread abnormalities appear. An early EMG may be inconclusive, especially if sampling is limited to symptomatic regions. A normal or borderline study provides false reassurance and delays repeat evaluation. Time becomes the decisive factor. ALS is diagnosed retrospectively as much as prospectively. Progression reveals the pattern that was not initially visible. By the time diagnostic criteria are met, significant motor neuron loss has already occurred. The diagnosis confirms damage rather than preventing it. Psychiatric mislabeling adds another layer of delay. Preserved cognition, emotional distress, and inconsistent performance invite assumptions of anxiety, depression, or functional disorder. These labels persist because the patient remains articulate and engaged. The disease advances while credibility erodes. The diagnostic failure is systemic, not individual. Each specialty evaluates a fragment accurately within its own framework. What is missing is early unification. ALS does not announce itself with a single dramatic sign. It announces itself through progressive failure of voluntary movement. It does not fit neatly into any one specialty's domain. By the time ALS is named, the question is no longer whether the disease is present. It is how much irreversible motor neuron loss has already occurred during the period of fragmentation. Progression paths, how bulbar and spinal ALS converge. ALS does not remain confined to its point of entry. Whether the disease begins in the bulbar motor nuclei or in the spinal anterior horn cells, progression follows the architecture of the motor system. What appears early as two different clinical forms converges into a single, unified failure of voluntary movement. Progression in ALS follows motor networks rather than arbitrary timelines. Degeneration spreads to anatomically adjacent motor neuron pools through contiguous pathways. In Bulbar-Onset disease, involvement of the brainstem nuclei controlling speech and swallowing is followed by spread into cervical spinal segments, affecting the upper limbs. In Spinal-Onset disease, degeneration often ascends toward bulbar nuclei or descends toward thoracic segments controlling posture and respiration. The direction may vary, but the endpoint does not. This convergence is not sudden. It unfolds gradually as compensatory capacity is exhausted. Early in the disease, remaining motor neurons increase firing rates and recruit additional muscle fibers to preserve strength. This compensation creates temporary plateaus and fluctuations that are misinterpreted as stabilization. In reality, compensation accelerates metabolic stress on surviving neurons, hastening their failure. As spread continues, functional losses begin to overlap. A patient who began with limb weakness develops slurred speech. A patient who began with dysarthria notices hand weakness. The distinction between bulbar and spinal onset loses practical meaning. What matters now is the cumulative loss of motor units across systems. Respiratory involvement marks a critical phase of convergence. The diaphragm is innervated by phrenic motor neurons originating in the cervical spinal cord. As degeneration reaches these neurons, respiratory mechanics fail. The patient does not lose the sensation of breathing difficulty early. Instead, ventilation becomes shallow and inefficient. Carbon dioxide retention increases gradually, producing fatigue, morning headaches, and sleep disturbance before overt shortness of breath appears. Accessory respiratory muscles initially compensate. The chest wall stiffens. Breathing becomes effortful. Eventually, compensation fails. Non-invasive ventilation may prolong survival by supporting gas exchange, but it does not halt neuronal degeneration. Respiratory failure is not an isolated complication. It is the inevitable outcome of motor neuron system collapse. During this phase, bulbar dysfunction complicates respiratory support. Weakness of facial and pharyngeal muscles impairs mask fit and airway protection. Secretions accumulate. Aspiration risk increases. These factors shorten tolerance for ventilation and accelerate decline, regardless of initial disease entry point. As convergence progresses, communication becomes increasingly difficult. In Bulbar-Onset disease, speech may already be lost. In Spinal-Onset disease, speech deteriorates later. In both, writing and typing fail as hand function declines. Alternative communication methods rely on eye movements or residual muscle control, which themselves may eventually weaken. Throughout this progression, awareness remains largely intact. The patient perceives the narrowing of options. The nervous system continues to generate intention, but the pathways required to execute that intention are disappearing. This preserved awareness amplifies psychological distress, but it does not alter the biological trajectory. By the time bulbar and spinal ALS fully converge, the disease is no longer ambiguous. Voluntary movement across multiple systems has failed. Feeding, communication, mobility, and respiration are compromised. The distinction between entry points becomes irrelevant. The disease has revealed its full scope. This convergence exposes a central truth of ALS. The disease is not defined by where it starts, but by where it ends. All forms progress toward the same outcome: loss of voluntary motor control with preserved sensation and consciousness. The timeline varies. The sequence varies. The destination does not. Understanding convergence clarifies prognosis and reframes early distinctions. Bulbar ALS is not a separate entity racing ahead. Spinal ALS is not a slower, safer variant. Both are manifestations of the same motor neuron degeneration, unfolding according to anatomy rather than mercy. What remains after convergence is not uncertainty, but inevitability. The nervous system has crossed from localized failure into systemic collapse. From this point forward, progression is measured not in symptoms, but in remaining functions.
Preserved awareness. Execution fails while the mind remains. ALS is uniquely devastating, not because it erases thought, but because it leaves thought intact while dismantling the machinery required to act on it. Unlike many neurodegenerative diseases, ALS does not primarily target memory, perception, or reasoning. It targets execution. The mind remains present as the body becomes progressively unresponsive. Cognition in ALS is largely preserved because the disease selectively affects motor neurons rather than cortical associative networks. Sensory input reaches the brain normally. Visual, auditory, and tactile information is processed accurately. The patient understands speech, recognizes faces, and forms memories. Emotional awareness remains intact. The nervous system knows what is happening as it unfolds. This preservation creates a specific form of distress. The patient experiences loss not as confusion, but as entrapment. Intentions form normally. Commands are generated in the motor cortex. What fails is transmission. Upper motor neurons can no longer carry signals effectively, and lower motor neurons can no longer execute them. The pathway between thought and action disintegrates. In bulbar ALS, this disconnection is felt first in communication. The patient knows what they want to say. Words are selected correctly. Syntax remains intact. But the muscles of articulation cannot respond with precision or strength. Speech slows, slurs, and eventually disappears. The inability to speak is not loss of language, it is loss of motor output. In spinal ALS, the disconnection manifests through physical dependency. The patient knows how to perform tasks, but limbs cannot respond reliably. Reaching, grasping, standing, and walking fail despite intact sensation and planning. The body no longer obeys commands it once executed automatically. This mismatch between preserved cognition and failing execution intensifies fear. The patient witnesses their own decline without the protective buffer of confusion or denial. Awareness does not fade early, it sharpens. Each loss is recognized as permanent. Each adaptation is understood as temporary. Communication technologies attempt to bridge this gap. Early in the disease, typing and writing compensate for speech loss. As hand function deteriorates, adaptive keyboards and switches are introduced. Eye tracking systems become the primary interface between thought and expression. These tools extend communication, but do not eliminate dependence. They rely on residual motor control that may eventually fail. The distinction between ALS and locked-in syndrome is important. In locked-in syndrome, the lesion is focal and static. Consciousness is preserved, but the body is acutely immobilized. In ALS, immobilization is progressive. Control is lost gradually, piece by piece in full awareness. There is no single moment of transition. There is accumulation. Emotional expression becomes distorted as motor control declines. Facial muscles weaken. Voice modulation disappears. The patient may appear emotionally flat or disengaged despite intact internal experience. Caregivers misinterpret this as depression or withdrawal. In reality, expression has become mechanically inaccessible. Autonomy erodes even as decision-making remains intact. The patient understands risks, benefits, and consequences. They participate in planning. They make choices. The difficulty lies not in deciding, but in acting. This asymmetry complicates ethical and medical decision-making. The individual remains mentally present while physically dependent. As disease progresses, even eye movement control may weaken. Communication slows, effort increases, fatigue dominates. Still, awareness persists. The patient continues to observe decline until late stages, when respiratory compromise and metabolic stress may finally blunt consciousness. This preservation of awareness is not universal, but it is common enough to define the disease's emotional weight. ALS does not typically erase identity early. It confines it. The self remains intact inside a system that can no longer translate intention into action. This is the core pathology of fear in ALS. The disease does not remove the mind from the body. It removes the body from the mind. And because awareness remains, the loss is experienced continuously, without relief. Understanding this distinction is essential. ALS is not frightening because patients forget who they are. It is frightening because they remember exactly who they are while losing the ability to express it. The point of no return. Respiratory failure as system collapse. ALS does not become irreversible when a diagnosis is made. It becomes irreversible when the motor neuron system can no longer sustain respiration. This moment does not arrive suddenly. It is approached gradually through loss of redundancy, compensation, and physiological reserve until breathing itself becomes mechanically unsustainable. Respiration depends on voluntary motor control more than is commonly recognized. The diaphragm, the primary muscle of breathing, is innervated by lower motor neurons originating in the cervical spinal cord. These neurons fire rhythmically and continuously, translating neural signals into mechanical ventilation. In ALS, when these motor neurons degenerate, the diaphragm weakens despite intact lung tissue and normal oxygen diffusion capacity. Early respiratory involvement is subtle. The patient does not feel short of breath during exertion at first. Instead, ventilation becomes inefficient during sleep when voluntary compensatory effort is reduced. Carbon dioxide levels rise overnight. Morning headaches develop. Sleep becomes fragmented. Fatigue deepens without clear explanation. These signs are often misattributed to anxiety, insomnia, or deconditioning. As motor neuron loss progresses, accessory respiratory muscles attempt to compensate. Intercostal muscles stiffen the chest wall. Neck and shoulder muscles engage to assist inspiration. Breathing becomes effortful and visible. The patient remains fully aware of the increased work required to breathe, yet lacks the ability to strengthen the failing muscles. This phase marks a critical transition. Once respiratory muscles weaken beyond a threshold, no physiological mechanism can restore effective ventilation. The problem is not airway obstruction or lung disease. It is failure of execution. The brain continues to generate the command to breathe. The motor neurons can no longer deliver it. Non-invasive ventilation can temporarily support gas exchange. It reduces carbon dioxide retention, improves sleep quality, and relieves dyspnea. However, it does not halt motor neuron degeneration. Ventilatory support delays consequences. It does not change trajectory. Bulbar involvement complicates this stage significantly. Weakness of facial, pharyngeal, and laryngeal muscles interferes with mask seal, secretion management, and airway protection. Aspiration risk increases, secretions accumulate, respiratory infections become more likely. These factors shorten tolerance for assisted ventilation, regardless of initial disease onset. As respiratory failure advances, metabolic stress increases. Carbon dioxide retention affects cerebral function. Consciousness may finally dull, not because cognition has been erased, but because physiology can no longer sustain wakefulness. This is often the first relief from constant awareness, and it arrives only at the end. At this stage, the disease has crossed the point of no return. No intervention can restore motor neuron populations. No therapy can re-establish voluntary respiratory control. The nervous system has lost the final pathway required for independent survival. This moment defines ALS as a terminal motor neuron disorder. Not because death is imminent at diagnosis, but because the endpoint is biologically fixed. The disease does not plateau. It does not stabilize spontaneously. It progresses until the motor system can no longer support life. The fear here is not abstract. It is mechanistic. Breathing, the most fundamental voluntary act, becomes impossible not because the lungs fail, but because the nervous system can no longer execute the command. The patient understands this as it happens. Awareness persists until physiology collapses. Respiratory failure is not a complication of ALS. It is the inevitable outcome of motor neuron system collapse. When it arrives, the distinction between bulbar and spinal ALS disappears entirely. The disease has reached its final common pathway. From this point forward, care focuses not on recovery, but on management of an irreversible biological limit. The nervous system has done all it can. The machinery required for survival is gone. Stable aftermath. After ALS reaches the stage of respiratory dependence, the disease enters a stable aftermath. Progression may continue in degree, but the fundamental nature of the condition no longer changes. The motor neuron system has lost the capacity to execute voluntary movement, and no intervention can restore that capacity. There is no treatment that reverses motor neuron death. Current therapies may slow progression modestly in some patients, but they do not regenerate upper or lower motor neurons once they are lost. Muscles do not fail because they are diseased. They fail because their neural input has disappeared. When that input is gone, strength cannot be recovered through effort, rehabilitation, or time. Care at this stage becomes explicitly supportive. The goal is not recovery, but stabilization and safety. Nutrition is maintained through alternative feeding methods when swallowing is unsafe. Communication is preserved through assistive technologies for as long as residual motor control allows. ventilatory support replaces failing respiratory muscles. Each intervention compensates for a function that can no longer be executed voluntarily. These measures do not alter the underlying trajectory. They extend life by replacing lost execution, not by repairing the system that failed. As motor neuron loss continues, the margin for compensation narrows. Each new loss reduces flexibility. The nervous system becomes increasingly fragile to stress, infection, and metabolic imbalance. Throughout this phase, awareness often remains. The patient continues to perceive their environment, recognize loved ones, and understand conversations. Emotional experience persists. The distinction between inner experience and outward expression widens. Identity is not erased. It is constrained by biology. This is why ALS is frequently misunderstood. It is not a disease that dissolves the mind. It is a disease that disconnects the mind from the body. The individual remains present within a system that can no longer carry out intention. This separation defines the lived experience of the disease. Bulbar and spinal forms are no longer distinguishable at this stage. The initial point of entry has lost relevance. What remains is a global failure of voluntary motor control. Speech, movement, swallowing, and breathing are all affected because they share the same execution pathway. The disease has completed its convergence. There is no sudden collapse. There is no dramatic transition. The aftermath is defined by absence rather than chaos. Absence of strength, absence of coordination, absence of voluntary control. What remains is a stable condition, shaped by irreversible loss. This outcome is not the result of missed treatment or insufficient effort. It is the consequence of a biological process that medicine cannot yet stop. ALS does not punish behavior. It does not respond to motivation. It follows the rules of motor neuron degeneration until those rules exhaust the system. The fear associated with ALS is not symbolic. It is not philosophical. It arises from understanding what is happening and being unable to intervene. It is the fear of preserved awareness inside a body that can no longer respond. It is the fear of knowing that intention alone cannot move muscle once the pathway is gone. This is pathology of fear, not because ALS is mysterious, not because it is misunderstood, but because it is fully understood and still unstoppable. And this fear is real.